Okay, so this video will be about volume control or assist control. Sometimes we're even saying the word assisted volume control to describe this. When you're using assist control or volume control, you'll set a number of different parameters. One of them is the rate, how many breaths per minute. Typically we might say something like 15 breaths per minute. You'll set a tidal volume, which we describe as V subscript T. Typical tidal volume might be something like 7 mLs per kilogram. If you have a 70 kilogram person, that would be something like 500 mLs. Since May of 2000, it's been traditional to use 6 mLs per kilogram. That would certainly be a safe choice for most patients. FiO2, you'll set an FiO2 that might be something like 50%. And you'll set a PEEP. Typical PEEP might be something like 5. And then a flow will need to be set. In our hospital, usually the respiratory therapist will try a few different flows and try to optimize that. Physician doesn't typically prescribe the flow, but somebody needs to. We need to tell the ventilator what flow rate to use. Typical flow rate might be something like 60 liters per minute, which I think you can appreciate would be the same as 1 liter per second. Okay. So let's kind of go through how this will work. First of all, the ventilator will be keeping track of the airway pressure. The ventilator can do that in different places. You can do it inside the vent circuit. You could do it at the Y. You could even put a tube through the endotracheal tube and measure it in the trachea. Nobody really does that because of problems with condensation and mucus plugging up the tubing. Most modern ventilators are measuring pressure inside the circuit, but for our purposes, let's assume we're measuring it at the Y, because I think it's just a little bit easier to visualize when you're new to how ventilators work. So let's just think about what the pressure would be there at the Y. The ventilator we'll usually have the ventilator tell us, show us a tracing of the pressure as well as a tracing of the flow over time. With flow, we'll have a 0 line. That means there's no flow going on. And then by convention, above the 0 line is inspiratory flow, below the 0 line is expiratory flow. Further away from the line you are, the faster the flow. Okay, at the end of a breath, if we have the PEEP set at 5, we've got 5 there, we'll have the inspiratory valve closed as we're at the end of expiration. Normally, all things being fairly normal, alveolar pressure will be 5 at the end of the breath. So airway pressure being measured at the Y will also be 5. And if you're tracing the pressure, you'll be about 5. And there'll be no flow at that time. Okay, the first thing that'll happen is the patient will make an inspiratory effort. The diaphragm will go down. The external intercostals will raise the rib cage up and out. When that happens, that drops the pressure inside the thorax, so pressure here will fall. If the inspiratory muscles make enough of an effort, then we'll drop the pressure not just here, but also up through the circuit to here. And if we're using a pressure triggering system, then what we'll usually do is tell the ventilator to be triggered when the airway pressure gets to 2 less than the set PEEP. Okay, 2 less than the set PEEP. So if we've got the PEEP set at 5, then when the pressure here gets to 3, then that would be the trigger to the ventilator to say, okay, the patient wants to breathe, give a breath. And when that happens, the expiratory valve will close, the inspiratory valve will open, and the ventilator will use whatever pressure is necessary to push in 500 mLs at a rate of 60 liters per minute. So if we're tracking that airway pressure, we'll see the little dip when they make their effort, and then we'll see the airway pressure goes up as the air is pushed in. And flow will be, if we tell it to give 60 liters per minute throughout the whole breath, flow will look like that. Now, if you tell the ventilator to give 500 mLs at a rate of 1 liter per second, I think you can appreciate, again, that would be half a second. So inspiration is going to take half a second. Let's think about what's happening right before it finishes, right about that time. What's happening? Well, at that point in time, airway pressure here at the Y might be something like, we'll just say 28. Pressure in the alveoli might be something like 20. There's still a pressure gradient from the Y to the alveoli, so there's still flow going into the lungs. And then when we hit that 500 millisecond mark and we've put in all 500 mLs, then the expiratory valve will open, the inspiratory valve will close. we'll have a pressure gradient of 20 here and 5 here, so air will flow out. The first air to come out will come through this tubing. That tubing is pretty big. Air flows really easily through that, so expiratory flow initially is pretty fast. As that air comes out, then we'll start to see air come out from the alveoli and the bronchial tubes. As air empties out of the lungs, the alveolar pressure will start to fall. It'll get to something like 15. As that happens, expiratory flow will start to decrease. Time goes on, this continues to get a little lower. Let's say it gets to 8. Expiratory flow continues to get a little bit slower, but you still have flow going out because you still have a gradient. And then eventually, again, assuming fairly normal circumstances, alveolar pressure will get all the way back down to 5, and then there'll be no flow until the next breath. Airway pressure here at the Y, once this valve opens, falls pretty quickly. There's not a lot of resistance between those 2 points, so airway pressure will fall pretty close to 5 pretty quickly until we get to the next breath. Now, a couple of thoughts. First of all, we set a rate of 15. What that means is that if the patient never triggers the ventilator makes sure they get 15 breaths. So that's sort of a minimum number of breaths that they're going to get. If the patient triggers the ventilator 20 times, then each of those 20 times the ventilator will push in 500 mLs at a rate of 1 liter, at a rate of 60 liters per minute. Word about expiratory time here. You know, if you have 15 breaths per minute, that's 4 seconds per breath. Inspiratory time is going to be half a second, so expiratory time will be 3.5 seconds. On the other hand, if the patient's triggering and the patient gets 20 breaths per minute, then that's 3 seconds per breath. Inspiratory time is still going to be half a second. Expiratory time in that situation will be 2.5 seconds. Expiratory time is just simply whatever's left over. So I think you can appreciate if we get to really fast respiratory rates, then expiratory time gets shorter and shorter. We need to keep that in mind. A couple other things. I assumed here that flow was constant throughout inspiration. We actually typically use a ramp, and I'll explain why in later lectures, but typically we'll use an inspiratory flow waveform that looks sort of like that, which is to say the peak inspiratory flow is whatever you said, in this case 60 liters per minute, but then as the breath goes on, inspiratory flow will slow down and may even get to be pretty slow depending upon exactly how your ventilator runs its ramp. Period and Bennett's get to be pretty slow. By the end of inspiration, there's just not a lot of flow. When that happens, inspiratory time will be a little bit longer, right? Because you're still going to put in 500 mLs, but it won't be as fast of a rate through the whole time of inspiration. And then also I mentioned if you're having the ventilator be triggered by pressure, there are 2 ways to have a ventilator triggered. There's pressure triggering and there's flow triggering. We tend to use flow triggering because there are a number of advantages, but I describe this with pressure triggering because, again, I think it's just a little easier to conceptualize when you're new to it. Later on in a different video, I'll describe the differences and why we usually use flow triggering. Okay, so that's volume control. In our next video, we'll talk about one of the pressure regulated modes. We'll talk about pressure control because that's an important one to understand before you can understand PRVC, which is a very popular mode.